Hello, and welcome. Today we're diving into a very common ailment, especially among children, acute otitis media, or AOM. Simply put, it's a middle ear infection. We'll explore what causes it, how it develops, how it's diagnosed and treated, and importantly, what we can do to prevent it. So, let's get started. What exactly causes this painful infection? The primary culprits are bacteria and viruses. The most common bacterial offenders are Streptococcus pneumonia, Haemophilus influenzae, and Moraxella catarrhalis. Viruses responsible for upper respiratory infections, like the common cold or flu, can also lead to AOM. These pathogens travel from the nose and throat, up the eustachian tube, and into the middle ear, setting the stage for inflammation and infection. Now, let's talk about how AOM develops. The eustachian tube, normally responsible for pressure equalization and drainage in the middle ear, can become blocked. This blockage can be due to swelling from a cold, allergies, or enlarged adenoids. When the tube is blocked, fluid builds up in the middle ear. This fluid creates a warm, moist environment, perfect for bacteria and viruses to thrive. As the pathogens multiply, they trigger an inflammatory response, leading to swelling, redness, and pain, all characteristic signs of AOM. In severe cases, the pressure from the fluid buildup can even cause the eardrum to rupture. AOM is exceptionally common, especially in infants and young children. In fact, it's one of the most frequent reasons for pediatric visits. Children are more susceptible due to the anatomy of their eustachian tubes, which are shorter, more horizontal, and floppier than those of adults, making them more prone to blockage. While AOM can occur at any age, it's most prevalent between 6 months and 2 years of age. Certain factors like daycare attendance, exposure to cigarette smoke, and bottle feeding while lying down can also increase a child's risk. The symptoms of AOM can vary, but the most common one is ear pain, often described as a sharp or throbbing H. In young children who can't verbalize the pain, you might notice them pulling or tugging at their ear, being unusually fussy or irritable, having difficulty sleeping, or crying more than usual. Other symptoms may include fever, fluid draining from the ear, difficulty hearing, loss of appetite, and sometimes even vomiting or diarrhea. Diagnosing AOM typically involves a visit to a doctor or healthcare professional. They'll use an otoscope, a handheld instrument with a light and magnifying lens, to examine the eardrum. Key findings that suggest AOM include a red, bulging eardrum, and the presence of fluid behind the eardrum. In some cases, a pneumatic otoscope, which emits a puff of air, might be used to assess the eardrum's mobility. Reduced or absent mobility suggests fluid buildup. In certain situations, a tympanometry test, which measures the eardrum's movement and pressure in the middle ear, may be used for a more objective assessment. While we generally refer to it as acute otitis media, it's helpful to distinguish between acute otitis media with effusion and acute otitis media without effusion. AOM with effusion means that there is fluid present in the middle ear along with the signs and symptoms of acute infection, like ear pain and redness. AOM without effusion might indicate a resolving infection, where the fluid is slowly clearing, or a different condition entirely. Another related condition is otitis media with effusion, OMV, where fluid is present in the middle ear but without acute signs of infection. OMI is typically painless and may follow a recent AOM episode. Treatment for AOM depends on the severity of the infection, the child's age, and other individual factors. In some cases, particularly in older children with mild symptoms, a watchful waiting approach may be recommended for 48-72 hours, allowing the body's immune system to fight the infection. Pain relievers such as acetaminophen or ibuprofen can be used to manage discomfort. If symptoms persist or worsen, or if the child is younger than 6 months, antibiotics are usually prescribed. Amoxicillin is often the first-line antibiotic. In cases of antibiotic resistance or allergies, alternative antibiotics may be used. For recurrent AOM, ear tubes, also known as tympanostomy tubes, might be recommended. These small tubes are surgically inserted into the eardrum to allow for ventilation and drainage of fluid, reducing the frequency of infections. Preventing AOM involves several strategies. Ensuring children are up to date on their vaccinations, particularly the pneumococcal conjugate vaccine, PCV, and the influenza vaccine, can help protect against some of the common bacterial and viral causes. Breastfeeding, if possible, provides important immune benefits. Avoiding exposure to secondhand smoke is also crucial. Proper hand washing and hygiene practices can reduce the spread of germs. If bottle feeding, avoid propping the bottle up or allowing the child to lie down while drinking, as this can increase the risk of fluid entering the eustachian tube. The prognosis for AOM is generally excellent. Most cases resolve completely with appropriate treatment and management. However, untreated or recurrent AOM can lead to complications, such as hearing loss, speech delays, or, in rare cases, more serious infections like mastocytitis or meningitis. Recent research is focused on developing new vaccines to target emerging antibiotic-resistant strains of bacteria that cause AOM. There's also ongoing work on improving diagnostic tools for more accurate and rapid identification of the causative pathogens, as well as exploring alternative treatment options to reduce reliance on antibiotics. Thanks for watching, and we hope you found this information helpful. If you have any concerns about your or your child's ear health, always consult with a healthcare professional.